Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So for a patient who attended with bilateral fully occluding earwax and also some fungal spores in the right ear. So this is the left ear that we're commencing with now. This procedure is a technical challenge and you can just see why now. The patient's ear canals, and this is both sides, but at the moment on the left, it's completely collapsed at the entrance. So when you've got a collapsed ear canal at the entrance, the ear canal's shut. So how do we get two instruments into the ear? And this is what I teach all our clear wax delegates. So what I'm doing is I'm stretching the ear open, elevating the pinna. So the pinna is the external cartilage that looks like a satellite dish. If you retract that back and up, not only do you widen the ear canal, you straighten it. I then insert the eye clearscope endoscope into the ear canal, using it almost like a door stop to keep the canal wall open ajar, which then enables me to safely insert the suction probe. It is technically challenging. Does require a lot of skill. You need to have good hand-eye coordination. You need to be ambidextrous, good with both hands. It's not a clear wax delegates, when they come in the training course, they do struggle at the beginning and with practice, perseverance, and they do also have to have the underlying skill. I can teach someone all day, but if they don't have the underlying skill, then they're not going to be able to do it. But if they have and they follow the techniques I show them, there's no ear that you can't access using endoscopic earwax removal. So I'm sorry about that, I'm just narrating and my other computer is beeping at me. So we've cleared the blockage out, just some dead coating around the side, so just using a fine angle. Patient did get a bit dizzy, a bit of caloric effect that can happen. So you've got an organ of balance in both ears. They send messages to your brain. When you suction, it reduces the ear temperature. Therefore, in this case at the moment, the left ear is sending reduced messages compared to the right ear. So the brain actually thinks you're moving to the right, but the patient's not. The patient's sat still, looking straight ahead, and they therefore experience what we call the caloric effect. And they experience vertigo, the room's spinning around, the eyes rotate, and it settles within a minute or so. The ear temperature has to just come back to normal on the left side, back to room temperature after suctioning, and then the brain's getting equal messages. So we call that the caloric effect. So I'm just trying to get as much dead skin off as I can. So the patient's not yet experiencing the caloric effect, but they will do. And the reason why I'm trying to get this skin off, in most cases we'll leave it, it's just this patient's got a chronic history of ear infections, otitis externus, an infection of the ear canal. And you'll see on the right side, as I said, there is some evidence of some fungal spores there. The patient's eardrum on this side is also retracted. You'll get a close-up a bit in a moment. So when we say retracted, we mean the eardrums are buckled inwards, the eustachian tube, so you can see the attic, the top, the pars facida, what we call, it's just sucked inwards. So there's negative pressure behind the eardrum because the ear can't equalise itself. The eustachian tube, which is an orifice that connects the middle ear to the cavity behind the eardrum to the back of the nose, is blocked at the back of the nose, causing the eardrum to get sucked in. The eardrum's think about it like a piece of cling film. It sucks in. So if you've got a bit of cling film on your lips and you suck in, you're breathing that in. It sucks inwards in the same way the eardrum does that, and it wraps it around itself, around the bone. The hammer bone has got a projected bit at the front. We call that the short process or the lateral process. And the pars flaccida is the thinner part of the eardrum. It can get sucked in there, creating a pocket. So this is the patient's right ear. Again, the ear canal's completely shut at the entrance. We're just stretching the ear wide open. And you can see in that case, I managed to remove that plug of wax in one go. Now you can see on the anterior, so the right-hand side of the ear canal, the front part, should I say. So the anterior means the front part. So in the case of the right ear, the front part of the ear canal, facing the front of the face, is on the right-hand side. On the left, the anterior canal wall, the front part, the left ear would be the left-hand side. Now, it is very tricky getting this patient's ear. He's got a very narrow, twisted ear, as I mentioned. The cartilage is quite thick as well, so I've had to bend the fine end tip gorge just to get access onto this anterior canal wall. So that's not cotton wool. Patient has used cotton wool in the past, which give him a slap on the wrist for because he knows better not to. But this is fungal spores, otomycosis. So the patient's already receiving treatment for this, or repeat treatment. So they've had this in the past. So they've asked to contact their doctor who will re-prescribe the treatment. So some Canesten ear drops, antifungal drops. Sometimes ear calms, so acetic acid can also help over the counter. So I'm going to try and get as much of that fungal spores out as possible. It's something that needs to be treated really with medication. But now there's a few loose hairs here. I'm going to just try and pinch these out using some forceps. Yeah, the patient actually felt this one. So this was actually attached to the canal wall. They felt it being pulled out, plucked. There's another one to the left. There is one left right near the eardrum. It's too deep to use forceps because the tip of the forceps is a sharp edge, because that's so close to the eardrum. Just to approach it, to get the jaws around the strand of hair, it would mean the distal end of the forceps, the pointed bit, will come in contact with the eardrum. We don't want that because that could potentially perforate it. So I'm just using a fine end here. You can just see I'm gently just on the canal wall. It's like a game of operation here. We don't want him to make contact with that canal wall because the patient will flinch. And there's that hair that I have to got no other option but trying to suction it, but it's not going to come. It's not a problem. It's not causing them a problem. They didn't feel it in there. So I hope you enjoyed that video, guys. Take care. Speak soon.